Hi, we are in the Angio suite, and we have an interesting case this morning. Um, this lady is in the late 70s, and she presented to us with a long-standing history of vascular blockages in the legs. This is an example of how the plaque and atherosclerosis disease can affect the circulation of the leg and make the patient suffering from difficulty on walking and actually pretty much go around during the day on doing just basic activities. So we already make a small puncture in the left arm circulation is the brachial artery, and we have a catheter coming down into that direction. If we look at the screen, you will see a wire leading the path. The wire is located inside the aorta, and we're going down all the way into what we call the abdominal aorta, which is the lower portion of it. So right at this level, we have the end of the catheter. We're gonna hook this with a syringe containing some dye or some contrast material. We're going to inject that, and that will give us a mapping or the configuration of the aorta. In that way, we can identify where the blockages are. So what we're seeing right now is the silhouette of the lower portion of the aorta. Those two branches at the top are the kidney arteries. Is the artery that gives the blood supply to the kidney. You can see actually the shape of the kidney at the end of the rung. And then in the lower portion, I don't know if it's possible to see in the screen, she has two stents placed at what we call the bifurcation of the aorta. That's where the aorta divides in two limbs or two arteries, and those arteries are the beginning of the flow to the lower legs. And one branch goes to the right leg, the other one's supposed to go to the left, but we don't see that. What we see instead is an absence of flow between the end of the aorta and those two branches. And you can see in the background the mesh of the two stents that has been placed on her almost 5 years ago by another institution. So what I will try to do here is use this tiny wire that goes inside the catheter, and I will try to see if I can pass through the stent. And the options of treatment here is if we have the possibility to cross at least one of the stents, we can reopen that with different maneuvers. We can do another stenting, we can do angioplasty. All right, let's do something here. Let's do another picture, and let's look at the right groin. Let's see if we have what we call reconstitution. So I'm injecting in the aorta, the flow is coming through collaterals, and you can see the artery right there. So that's telling me that I have a chance also to come from below up and try to connect the two ends of the blockage. All right, so we shift from the arm to the right groin. So I'm gonna start doing a picture from below so I can show you the extension of the blockage. You can see my wire. If I move the wire up, you see it's gonna get stopped right there. I cannot make any progress because that's where the blockage actually started at the bottom. So I'm injecting from below so we can have what we call the roadmap. It's an image that we can use and work over there. And you can see how long is the occlusion. It's not only at the stent, it's a little beyond the stent. So we're gonna try to see if we can cross this blockage. You can see the wire went through. This is where we stand right now. We have access from the groin and from the left arm. If you can look at the screen, there's two catheters there. One is coming from above, the other one from below. We're going to get a picture of shooting simultaneously from both ends. Here we go. Now. So there's a large collateral right there coming up from the aorta. We didn't see that from above before, but now we're seeing it because I'm injecting a little lower in the area. The next step will be also to introduce a tiny catheter, which is very valuable. It's called IVUS. IVUS stands for intravascular ultrasound. It's a catheter that has the capability to show me the inside of the artery. It's very taper, very small device. Right in this area that is almost like a yellow color, there's a transducer. It's a technology that spins around and that recreates circumferentially the anatomy of the vessel that you want to interrogate or the vessel that you want to see. It gives you such a detail that you can identify plaque versus thrombus, and also can give you the dimensions of the artery. We can measure how big the artery is, how long is the blockage, and it's just give you the characteristic of the problem that you're looking at. So we're going to introduce that in a tiny wire. In a second, you see the round shape of the end of the sheath that we put from the brachial artery, and now this is the probe. The circle that we see right there is the probe itself. It has like a plus sign in the center, so that's the instrument. The circumference of the artery is the white around. So we are right now in the external iliac artery. I'm going to push down some more so we can find right there. This is normal flow. This is a normal artery right there. Let's measure the dimensions of this vessel right here. So we can use the caliper of the computer of the instrument, and then we can measure the dimensions. So this is a 9.4 millimeter vessel. I mean, it's a pretty good size for the area that we're looking at. So I'm going to do what we call a pullback. If we can do a pullback. Okay, let's go. And what we do is we create a two-dimensional view of the entire length of the run. So I'm going to come back, and now you can see that the flow stopped, and it's now kind of white color in the center. That's the plaque. And we're good. We are inside the vessel itself. And pretty soon we're going to approach the stent, and you will see the very bright marks of a stent right there. Sometimes looks like a sunburst coming off every time that we pass a cell. So we are in good location. Look at the stent here. It's completely collapsed. It's almost like an X shape right there. Very tight right here in this area. No wonder the vessel got occluded. And then I'm going to pull back the sheath so we can see better until we get into the lumen of the aorta. Right there, that's the aorta. All right, let's stop here the run. And let's measure the size and dimensions of the aorta. Maybe 12 in the face clock. We can do a measurement from the top, 12 to 6. So the aorta is close to 11 millimeter. All right, let's do something more interesting with the IVUS. Let me go back again. Now, we're going to add some color to the IVUS. This is an interesting feature because it will let you know where there's flow, and you can see that red color means that there's flow in the most of the lumen of the vessel. Remember, because we have the blockage at the top, we don't have a good push of flow through because it's just kind of very damp flow. But if I pull back, you will see that the red will eventually disappear as we approach the blockage. Now you see just a little tiny areas of flow around the probe that perhaps were created by itself in the attempt to cross this. As we go up, there's no flow at all. There's no red. And this is the entire length of a stent. Again, we see the collapse of the stent right there. And as we approach the aorta, we should be able to see flow again. Here we go. So that's the aorta, and there's good flow at that level. All right. So from above, what I will do is introduce a balloon first to make more opening on the stent, and perhaps we can come from below to do our stenting. You can tell the two radio-opaque marks that we have are going to move the catheter, so we all can identify the balloon right there. One is past the stent, the other one is above, so we're going to inflate this live. So you will see the contrast. We mix contrast with saline, and that way we can see the balloon in the screen. And you can see it fills up the two ends of the balloon, but in the middle is probably that area that we look at the IVUS that is very collapsed. And that's probably the culprit or the cause of the failure of a stent. Go up to 10. The patient sometimes feels this ballooning, a little back pain. We're doing this procedure actually with local anesthesia, and conscious sedation. It's a sedation, so it's kind of sleepy. And you can see we have a good expansion of a stent right there. Let's do it for a minute, please. So we keep the balloon inflated for 1 minute. And I think we need to dilate a little lower also, just to reach the other end of the blockage. All right, let's take it down. Right there. Okay, let's dilate it here. I'm pulling back the sheath so we can uncover the entire length of the balloon. Go ahead. Here we go. You can see there's some further narrowing down there. And we knew that because the IVUS identified that for us. So our next step here will be repeat the IVUS, look at this area. I'm assuming we're going to see a lot of irregularities, but at least we will see a circumference of flow that we did not have before. Okay? Yeah. Okay, here we go. This is an angio that we're doing. This is the first angiogram after we angioplasty this. All right. Now we have flow through. You know, when I met this patient, she told me that she barely can walk more than 50 yards without having pain. So we're using the IVUS one more time. And the reason that we're doing the second IVUS is to make our plan of how long of the artery we have to cover, how long is going to be our new stent. All right, pulling back. Oh, definitely a better pattern of flow. You can see how the red is filling entirely the circumference of the vessel. So we should approach the stent pretty soon here. You can see the burden of plaque in the left side between 9 and 6 in the clock phase. So even though it's been improved, you can tell that the nidus of the plaque and the burden of the plaque is still significant right there. So that's the stent. You see how stand up by the shining circumference of the metal. The stent itself actually doesn't look bad this time, but again, this is this collapse area. And that's the aorta right there. All right, so let me see where the probe is, right at the top, no? Very good. So let's go back to that two-dimensional view and get some measurements. I need to get the size and diameter of the iliac artery one more time, and that will get me the idea of how big should be the stent. So I know that there's plaque here and there. Right there is completely clean. So let's make a mark on the screen because I want to bring the stent all the way down to that point. And then I'm gonna come back here and get a measurement right at this level, which is the middle of the common iliac artery. Having these two lines, I will measure the distance from the lower line back into the top of a stent, which is right there. With this ruler, we're going to measure the length of the catheter that I pulled back. And based on this length, the stent has to be 10 centimeters So because the stent that we're using is quite big, what I will do is coming from below with the wire. Now that the vessel is open, you see how easy the wire now crossed. At the beginning, we couldn't come from below, but now the wire went through easy because it's completely open. You can see this is a cover stent. It's called Viavan from the Gore company. You can see the stent goes from this point here to this one. It's 10 centimeter long, and based on our measurements, should be enough to cover the length of a stent. It's crimped into the device. It has a mechanism in which that you have to pull a string to uncover a very thin layer of membrane that is maintaining the stent in that collapse mode. Once we get into the target, we're going to pull the string. I will show you that, and that will start deploying the stent, as you will see on camera. We have our markers in the screen. You can see the device coming in. The end is right there in one of the markers. So we're pulling back the sheath all the way above the stent. Keep going, right there. So we have two blue lines there in the screen. One at the top is telling us what is the end, the top end of a stent, and the other one at the bottom, which is the end of the common iliac, that we know that there's plaque extending all the way down to that point. So I'm going to bring it back just a tiny bit because I want to cover just a little bit above each end. And you can see how accurate was the measurement from the IVUS, which is just right on target, right there. This is the end of the catheter. It has this knob. I'm going to do a counterclockwise rotation, and then I start pulling this string, and you will see how the stent is going to start deploying on the screen. You have actually to pull a significant amount of it. You can see opening on the top, and it just come down, opening little by little until we reach the other end. Here we go. So to make sure that we have a good opening, we're going to balloon this a little more, and we will do that from below. All right, here we go. Coming up. All right, let's dilate it here. So we're going to inflate the balloon up to 12 atmospheres of pressure. Here we go. Go, 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 go. Down. And then we're going to get the other end right here. Let's get to 12 atmospheres too. We already witnessed that the previous stent was collapsed. Although this one is a different one, it's still a type of a stent that needs some force to make it go to the nominal size. The nominal size is the intended size of dimension that it should. So I'm using this balloon to reach that. Down. All right, so right in the order you can see the flow. So that's our new stent. It's definitely better flow and better lumen. Actually, it looks good. It's not as collapsed as it was the first stent. I think we had a pretty good result. The only thing that remains to do here is a picture. So let's do an angiogram. Now. All right. Yeah, I think we had a pretty good result. You can see flow through. The big branch that was on the left side that fit the other leg is still intact. I bet the pain on walking that this patient was experiencing is going to be gone. This was a complex case, even for endovascular approach, which is this kind of wire and catheter techniques. However, the alternative for this patient will be an open bypass, which is still a big procedure. It has to be done under general anesthesia. There's some risk involved on that, given her age and her past medical history. So I think this is probably the simplest way that we can actually improve the lower extremity circulation. All that she will have at the end, I will use a little closure device for the puncture site. And from here, actually, she's going home. So definitely there's a big difference between the two approaches. Well, thanks for your attention.